This short video is about few important points related to the topic of obstetric cholestasis, which are very important to remember for the long cases. Okay, the first slide is about the differential diagnosis of obstetric cholestasis in pregnancy. Okay, whenever a patient comes with the complaint of itching all over the body or raised LFT, we have to remember these points, these important differential diagnosis, and while taking history, we have to rule out all these things. Okay, so this first slide is dedicated to all those differential diagnoses, and I recommend you to memorize all those points. Okay, so first is that of obstetric cholestasis on the top when a patient comes with itching, raised LFT. Secondly, we have to think about any allergy as well, or worm infestation, or viral hepatitis, or scabies, or eczema, dermographia artifacta, atopic eruption, prurigo, pruritic folliculitis, polymorphic eruption of pregnancy, pemphigoid gestation is acute fatty liver of pregnancy, gallstone or obstructive jaundice, and acute hepatitis of pregnancy, which is a very rare condition, primary biliary cirrhosis, and chronic active hepatitis. Then the risk factors for obstetric cholestasis also include personal or family history of the obstetric cholestasis, multiple pregnancy because of increased hormone level, carriage of hepatitis C and presence of the gallstone, and then after IVF treatment because hormones like progesterone given in IVF, and in advanced maternal age. Now, coming to the pathway of the care of the patients with obstetric cholestasis, when a patient comes with obstetric cholestasis, usually in third trimester, there are characteristic age and worse palm and sole and no rash. So we have to think about maternal treatment and the fetal treatment. In the maternal treatment, we have to think about weekly LFTs, coagulation screen, liver serology, and auto antibodies, liver ultrasound scan, and we have to prescribe ursodeoxycholic acid, vitamin K, and antihistamine. Then we have to consult the patient regarding the pros and cons of IUL. We have to check LFTs 10 days postpartum, and we have to do active management of third stage of labor as the risk of the PPH, and the risk of recurrence is about 90%. We have to avoid estrogen-containing medications. Okay. Now, in the fetal treatment, there should be increased surveillance, CTG, ultrasound for the growth, Leica volume, and Doppler, and we have to think about the risk of the preterm delivery. We have to offer IUL at 37 plus weeks and continue fetal monitoring in the labor, and IM vitamin K postpartum should be prescribed to these patients. Now, what are the maternal complications? It's very important to know about all these complications because in the long case, we have to ask from the patient about those maternal complications, or my examiner might ask question related to the maternal complication. So that or those complications include maternal pruritus, sleep deprivation, worsening LFTs, risk associated with IUL, increased risk of the operative vaginal delivery, increased risk of cesarean section, which increases from 10 to 36%, risk of PPH, which increases from 2 to 22%. Okay, then the fetal complications. What additional risk is associated with the pregnancy is complicated by obstetric cholestasis? It's very important that obstetrician should be aware and should advise a woman that the incidence of the premature birth, especially iatrogenic, is increased. Women should be advised of the increased likelihood of meconium passage in pregnancies affected by obstetric cholestasis. Women with obstetric cholestasis should be booked in under consultant-led team-based care and give birth in the hospital unit. Thank you so much for your kind listening, and it would be very nice if you memorize all these important points related to the topic of obstetric cholestasis. Thank you so much, Allah Hafiz.